Hello and welcome to the ABCs of MIPS, our monthly broadcast looking at how merit-based incentive payments will impact your bottom line. I'm Carol Flagg of HITECH Answers. Thanks for tuning in today. On this program, we address your questions covering the full spectrum of the CMS payment program alphabet, including MACRA, MU, PQRS, VBM, and more. On today's program, we look at the year in review and what lies ahead in 2012. Our experts from SA Ignite include Tom Lee, founder and CEO of SA Ignite, and Beth Hoke. She's the VP of Client Services for SA Ignite. Tom, Beth, we're going to dive right in here because I know we've got an interesting show ahead and we want to leave time for a few questions. So I'm going to go on mute and turn this over to you.
Great, thanks, Carol. And I think you all can see me. We're doing a little bit of a different format here, fireside chat with a little bit of video. So I'm here from sunny, warm Chicago, where it's, I think, only warm and balmy, 5 degrees Fahrenheit or something like that. So glad to be here, and thanks for joining us. And so today we're going to cover a bit of a retrospective here with Beth Houk as well, familiar to many of you. So you'll hear from Beth. And in terms of what we saw and learned in 2016. What are some of the market, regulatory, and political drivers that are really emerging as we enter 2017 in terms of forces to kind of track and in terms of gauge the consequences of what they are in 2017. And then finally, some of our predictions, and actually my personal predictions and Beth's personal predictions for 2017 and beyond, and that'll be a lot of fun to talk about and share with you all. And then we'll have some open Q&A. Have gotten some great questions already about some of the nuances of the programs, and we'll go through that. All right, so let me kick things off. Is that really the one thing that has emerged very clear from 2016 is that this movement to pay for value truly is unstoppable. And in light of the election results and new appointments and political appointments and things like that, it continues to be a hugely bipartisan movement, certainly not just within the governmental side, but we're also seeing on the commercial side as well. That's really a good foundation to start on in terms of from an ecosystem point of view. And so what you all hear is that Beth will sort of chime in with any thoughts she has, and we're going to kind of keep this very conversational. So Beth will kind of jump in when she has something to add here. So actually, with that, let me actually hand it to Beth regarding the second point.
Yeah, Tom. I think for a fireside chat, it would be nicer if we did have a little fire going in the background. But at least I can see you. So the second point, the C-suite is heavily engaged in the movement, is something that we're seeing quite a bit in the field. And I kind of thought back on the very beginnings of meaningful use and what went on there, and we got a lot of CIO attention because people were adopting EHRs, making an enormous investment to do so, and then really finding themselves configuring their EHRs in order to meet those meaningful use measures. So a lot of C-level attention, a lot of incentive dollars at play at that point, and then that started to wane. So as the program matured, you kind of lost some of that attention and really moved into more of a program management function where it was running itself, if I can say that. What we're seeing with MIPS is something fairly similar. So there's a lot of dollars on the line, and as a result, the C-level attention that we're getting is not just at the CIO level, but it is at the CEO, the finance, the CFO is getting very involved, seeing what could possibly be coming down the pike. And so the level of engagement and interest in education on MACRA is and the QPP is really kind of growing and very significant as everybody kind of navigates this new movement.
Yeah, from my vantage point, I'm seeing very similar dynamic as Beth, you shared there. And I think the other part that's also different in terms of, you just kind of think back to the early days of meaningful use and when that was getting started, is that now the C-suite conversations are are even so much deeper than they were in the early days of meaningful use, because I think people are realizing that the MIPS MACRA APM portfolio, it really does impact, for the long term, different areas of healthcare operations. It really can't be kind of pigeonholed and say, okay, this is an ICU only project, like many organizations sort of treat meaningful use that way in early days, but that really is a part of the strategic movement to value-based, right? So, you know, I'm seeing that too. And so it's actually fostering a lot of healthy discussions and a lot of debate within health systems and provider organizations generally, between senior leaders of different functions, because now they realize that the stakes are so much higher, and it really is permeating kind of their long-term operational strategies. And that's something you didn't really see quite as much with MU, where it was a little bit more pigeonholed, you know, from the get-go as an IT-centric type of project. Great point there, Beth. So now we'd like to move on to another kind of obvious thing as to what brings us together. It's, you know, MACRA and all those components, impactful, complex. That's validated certainly from the final rule, all the pages in there, and how it's playing out in the field. But yet, you know, knowledge is low in terms of, particularly at the clinician level, we're still seeing, you know, relatively low amounts of knowledge and even sometimes lack of awareness, even at this late stage. And with January 1st around the bend, a lot of organizations are really focused on the education effort. That's almost one of the most common areas in which we have seen organizations start with at this point of the year. You know, another area is that really provider revenues are uncertain and budgets are tight. I think, you know, one of the common headlines that I believe that many of you all have seen are when a major health system misses its revenue targets by some huge amount, all right? Or when organizations are starting to see the consumerization of retail, the conversion to retail of certain parts of their business, where you have new entrants coming in. And that's causing a lot of uncertainty and volatility, and really where provider revenues are really going to go. The predictability of it's getting less and less. And that, of course, has been an impact on budgets in terms of getting ready for a program like MACRA or any other value-based transformation. It does require resources, and so organizations are sort of feeling the squeeze from the top as well as from the bottom. And now, more than ever, organizations are focused on trying to get the most out of what they can put towards an effort, and even more so, again, as compared to the last couple of years of value-based programs, meaningful use, and others.
Very true. So one of the things that we also noticed is that the providers and provider organizations that do a lot of the work to make these transformations are really shifting from just acquiring to optimizing health IT. So what I see is, again, kind of reflecting back on the early days of MU, people adopted EHRs at record rates. So people were putting those systems in order to meet those minimum requirements and get those incentive dollars rolling. As things have evolved, what we're really seeing quite a bit now is a lot of people kind of taking another look at the EHR that they originally used and really upgrading or I should say substituting for what they're using right now to something that they think can take them into the next 10 years and meet some of the heightened requirements of interoperability. So although I think probably 5 years ago when they were doing the initial installations, many people swore they would never do it again. Many people are doing it again in order to really optimize their health IT technology so that they can meet these requirements of these value-based programs.
Yeah, and one other example of that is one specific example is that there is also a focus more now on data quality too, and that's part of the optimization process, particularly for EHRs. And we think about electronic capture of information. We've heard that quite frequently, and I think it's not only part of the overall sort of best practice of optimization, but organizations are now starting to realize that in order to engage clinicians in the way that they need to be engaged to really move rapidly towards that value-based transformation, the clinicians in particular, they've got to believe the data, right? And if there's a dissonance between what they know that they're actually doing versus what's actually captured within that record and how it's being reported out back to them, as well as, most importantly, to payers, then the dissonance really creates a real problem in terms of trying to move down to the real grassroots of an organization, the real transformation, the real belief that the value-based movement is going to definitely, create its share of winning opportunities versus it being purely a punitive type of transformation. And so, a lot of activity there. Beth's point, and Beth, you and I have been in a number of conversations like that together, with various organizations, and it's very real. People are focused on that, and they really want to get, finally start to really see that return on the millions of dollars they put into, let's say, an EHR installation, optimization, and they're very big investments, and many of those returns have not really come back yet. They tend to have like a long tail, on that sort of big iron type of implementations.
That's right.
All right, so finally, yeah, and one thing that is Beth, as you alluded to, the interoperability piece is really starting to gain some momentum, and certainly from the federal side, and we'll talk about the 21st Century Cures Act, I believe, a little bit later on, as well as some movement in the market among the vendors, is that the investment that the country has made in digitizing health data, the $30 billion plus, is really now that there's a really strong desire among all stakeholders, and particularly the government, which spent the money, to really get a return on that. And a big part of that return can only be gotten by enabling the patient record to truly follow the patient a lot more than it is today. And it's really interesting to see, even in the last month, how that's evolved and gained even further steam that I think is really going to persist throughout 2017. And that's got some real impacts as far as really everyone that touches healthcare data is potentially going to see opportunities and potentially even some threats from that. All right. So as we kind of transition into what Beth and I see in our respective crystal balls, we thought it would be useful to just lay out in one slide what are some of the key big drivers, of change and trends within 2017. We split them into these three different categories in terms of market, and that can involve really consumer demand and competition, things like that. Obviously, from the governmental regulatory side, as well as really the political changes that have already started. And so let me talk a bit about the market side, and Beth we'll share some of her thoughts and we'll have a little bit of conversation here. So from the market side, what we're seeing a lot of is these two forces on the market really emerge in a lot of conversations that we're in. First is this recognition that as much has been talked about with respect to consumer-driven purchasing over the last 3 to 5 years, that with the changes coming in Washington, with insurance exchanges having their challenges, there's just more and more, it's more and more likely that more and more will be put on the consumer out of pocket in terms of what they have to spend, and that to the extent that there's a desire for much more transparency into what consumers are getting for their money, that we're consistently hearing and seeing for ourselves that this awareness of what it means, what it's going to mean to really do well strategically long term, increasingly does have to be oriented towards the consumer, just like many other areas of consumer purchasing. All right, and obviously in healthcare it's a lot more complicated, there's a lot more regulatory impacts, things like that, but the general trend is we're really starting to see that in multiple facets going into 2017 as we really work with a lot of our clients and see what's out there. The other part is obviously the consolidation piece. Now that could be really consolidation of healthcare providers, even among vendors. We perceive a significant consolidation activity there, so that's something to also really be aware of. And the underlying drivers behind that is that there is, because of the increasing regulatory and administrative work that needs to be done to do well as a health system or a provider organization, that's really driving a lot of the small organizations to look for a larger home in which to share that cost. All right, so we could be talking about MIPS, we could talk about any number of these alternative payment models, or even on the commercial side. That's clearly been something that has been theorized about, but it's really happening, and we see that kind of further accelerating next year. Beth, anything you care to share on this side regarding the market?
Sure. Yeah, in the field, I think probably the one area that we talk about the most and that gets the most raised eyebrows and some concerns is everything related to this consumer-driven purchasing. We always say the 100-point scale that MIPS is measuring providers on is not by accident. It's because it's easy to understand. And making that information visible to the public in a way that's easy for the consumers to understand will most certainly be another data point to help them drive some of their purchasing decisions. Interestingly, I will say that I think there is some geographic differences in this. So some of our more West Coast folks have, partially because of their evolution on certain types of payment models, have not experienced this or have not necessarily as strong of a concern related to it as some of the others that are in these more highly competitive markets that are generally on, say, more older payment models. Some of the remaining fee-for-service models. So, regardless, this consumer-driven purchasing is likely to really be a driver, and you'll see in my predictions a driver of much behavior change in the market.
And it's really interesting. I'm going to actually jump to the regulatory one there, but do a kind of make a point by way of transition. Is that it's really interesting to see how, from the governmental side also, that they're really trying to catalyze some of this in terms of consumer transparency. So, for example, one of the recent questions that we got clarity from CMS on was that if you report for MIPS as a group, does that mean that your individual clinicians will be in a way hidden from having their name attached to a score, right? Because it may not be so clear which clinicians are within a particular group when it comes down to consumers trying to compare clinicians, trying to search for a new clinician. And what it turns out is that what CMS has clarified to us is that actually all individual clinicians will be listed on the Physician Compare website or available in the downloadable file of all the MIPS scores to be coming. And then in cases where there's an individual clinician that's part of a large group that's reported as a group for MIPS, nevertheless, the individual clinician will be listed separately, and in fact, there'll be a one-click link from that individual clinician's profile and Physician Compare directly to the group, which directly shows the score of the group. Okay, and that'll be interesting because some clinicians are going to be very happy with that because you'll look at that group score and say, oh, I'm really glad I'm part of this group because otherwise I would have scored much lower. But on the other hand, there may be clinicians that are not so happy with that. They see that score is not so good, and they realize that consumers can see that too, and they think that they could have done better if they were reporting individually. So by making that linkage down to individual clinician level uniform across, regardless of how one really reports, the visibility to the consumer is something that we feel that CMS is being very intentional about. And even with the new administration coming in, one could even see from sort of the track records of the folks coming in charge now that there is this drive towards value-based and really a lot of the things that MACRA really is putting in place is going to keep on gaining momentum. And so as that is a transition, obviously MACRA missed APMs. We'll have some predictions around that in terms of what may happen, what may go faster, what may go slower in just a moment. The 21st Century Cures Act is one that's fairly late breaking, that's been making the headlines the last couple of weeks. One of the key drivers around that in terms of from a value-based and the health IT perspective is this drive towards interoperability within that act. And it basically has provisions that are going to be hammered out in the rulemaking over the next 6 to 9 months that include things like requirements that vendors, health record vendors, expose every patient data element through some relatively easy to access interface for third parties to be able to get that data. Okay, and right now it's sort of like a straw in terms of the amount of that information that really gets out there. There's a lot of practical and economic reasons, but really this act is saying that in order for vendors to maintain their certification, they're really going to have to make that straw into a very wide pipe, and on a timeline too, and that is going to have some implications, I think, in terms of where vendors and others need to spend their time for the next 12 to 18 months. We'll kind of come to that. But that's kind of what that is. And then, of course, potential partial modification or repeal portions of Obamacare ACA. Certainly something that's going to continue to dominate the headlines right from the first day of the new administration. And I think we've talked before in terms of how MACRA is separate and really is strongly bipartisan. But there will be some areas where of uncertainty now, such as with respect to some alternative payment models under MACRA that are actually right now being operated by the CMS Innovation Center, where the CMS Innovation Center itself could undergo change because of some changes to Obamacare. All right, and that is something that a lot of folks are looking at, and I'll kind of come back to that in the next slide. So that's kind of regulatory side. Beth, what are you seeing in the field with clients, regarding some of these issues here on the regulatory side?
Yeah, I think the overriding thing that we're hearing, or I guess questioning in the field, is really what is the impact of the new administration, some of what you just covered, because I think that we've gone through so many months of uncertainty. The proposed rule was out there, nobody knew what the final rule was going to be, and then the final rule gets published, and shortly thereafter we have a new administration in place, and I think the combination of those things make people very unsteady. How is this specifically going to impact me, and do I have to be concerned that investments I'm making might be for naught going into the future? So the information and kind of predictions we make around how MACRA, with its bipartisan support and just basically because of what it stands for, that it won't be touched is comforting in the market.
Yeah, and those are great points. And the way some of these tied some of the drivers that we showed on the previous slide is that if we talk about revenue uncertainty for provider organizations, certainly those that are very highly indexed on Medicaid, given that Medicaid is one of the most modifiable pieces of ACA, and the incoming CMS administrator has some really deep experience working in the Medicaid side, within Obamacare at the state level, would lead one to believe that that the Medicaid revenue in particular is something to really keep a very close eye on in terms of how things really get off to a start next year, and really even beyond even just the funding of Medicaid and how that might be converted to a state block program, for example, block grant program. But on the value-based side of Medicaid, where there's a significant amount of activity happening at the state level, there really could be some things to really keep a close tabs on. Places like New York, California, where there have been really a lot of innovation done on Medicaid, and a significant resources in. Like, what does this really mean for that side? I think for those of you on like Medicaid meaningful use, we think that's pretty solid. That's really been baked in from the beginning. That's a program that's well on its way, and there's still some years of incentive to get there. I'm more referring to the fundamental Medicaid funding for care, and sort of the things that surround that around value-based, the things really keep close tabs on. So, all right, and so the kind of third eye, where we've already alluded to, is from the in terms of political appointments, what's changing there. I think that there's been already quite a bit written about, in particular, new appointees, Representative Price and Ms. Verma to CMS posts. And I think that what I'm seeing is that there is a lot of analysis and discussion about, okay, what's going to happen when the new leadership of HHS and CMS get in there, and then they really see the gears that are already in motion, right? And it's kind of sort of a similar thing to what folks talk about when we talk about Obamacare and ACA modification or partial repeal. And it's about, okay, what happens when the kind of the strategic vision sort of meets up against the reality of the things that are already in motion, and in terms of making adjustments to it, particularly around the alternative payment models with the CMS Innovation Center, where's that balance really going to fall in terms of what can practically be done on what time scale versus how the vision of this new administration may be different from the previous one in terms of where things go. I think the one thing that is universal is still this push towards value-based. So it's often more about potential different views about how to get there versus what the final goal is. The final goal is still to move to a value-based system. But the path in certain areas, again, alternative payment models is a big area of, I think, with a little bit more volatility and uncertainty right now, is going to get the lion's share of attention, I believe, once the new folks are in place. Beth, what are your thoughts of this? What are you kind of hearing clients say in terms of from the political side, how they're looking at it?
Yeah, well, I'm going to tell you what they say and ask you a question at the same time, Tom, kind of representing them. One of the things that I think we've been saying is that the Center for Medicaid and Medicare Innovation, CMMI, that creates these alternative payment models potentially could lose funding under the new administration because of some signals that they've previously had in their experience. One of the questions that I get a lot is around which APMs are safe. If we do start down the path and we know that that's the direction we should be headed eventually, which ones, where should I spend my time, or which ones do you think are the safest?
Yeah, this is great. We're getting a little bit also into some of our March Madness and analogous predictions too.
Yeah.
I think this is very so I'm seeing a number of things. The first is that well, first of all, let me remind you of just today even. Today, if you've been checking your inbox from CMS, we've already announced that the Next Generation ACO program and the CPC Plus program have the application period is going to reopen in January and February. Usually that's a couple years from now because they're off cycle every couple of years, but they're going to reopen that to try to get more people in. That was just announced. Just a couple of days ago, there were a couple more APMs that were announced at CMS. And, one could read that a number of ways in that, the outgoing folks in administration and many of the folks in CMS obviously are not political appointees, may very well stay there. But that one way to interpret that is that, they're really trying to get it out there, right, before it's transitioned to the new administration. The other way to read that is that, this overall move towards APMs is unstoppable, and that it's just the regular course of business, about the right time to get these things going. The final rule even mentioned reopening application periods for APMs, and it's just business as usual, right? And it's going to keep on going. And again, I think that is something to keep an eye on. To your question about what APMs might be more solid than others, obviously a lot depends on the leadership that's coming in, but what we can say, and this is from talking to a lot of folks in the field, organizations, is that some of the models, that already have significant numbers of providers and thereby stakeholders that are already operating the model are generally probably going to be subject to less volatility than those models that are very new and that have a smaller number of initial participants, okay? And that's kind of stating the obvious, but it's being confirmed by what we're hearing from organizations that are participating in these various different models. When you really get down to it, even operationally, there's some things contractually between these organizations at CMS that would take a significant legal effort to even try to say, okay, we're just going to cut you off. All right. So, but then there's other models, where maybe even there's no participants yet, and the application period is just opening up in the next couple of months, where one can look at that and say, okay, there might be more there that could be changed on a dime. And so I think the general advice is, in looking at your APM portfolio strategy the next couple of years, factor in, is there already existing momentum behind that? And of course, keep a very close eye, as we will be, in terms of the new administration coming in and what they do within those first 100 to 150 days. I think will be very, very indicative and telling about, where the tea leaves, what the tea leaves are really going to show for the subsequent 12 to 18 months. All right, great. We're doing. Yeah, thank you, Beth, for asking that question. It was great. All right, so now it's kind of the last piece here, and we've also, for those of you who may have been waiting for some, some of the more tactical advice, it's coming. We've gotten about, I think, 300 to 500 questions. I lost count over the last couple webinars. We actually plucked some of the more popular ones. We can get to those at the very end here. But let's wrap with our predictions. So Beth and I are big college basketball fans, and as you can attest to, we have our share of Big Ten rivalries and Pac-10 rivalries here within the company. When March rolls around, we have our little duke outs, and people are wearing the sweatshirts from their alma maters, things like that. And at the end of the day, it's hard to predict, right? Otherwise, people could automatically make a lot of money or very easy. But there's a lot of these, variables. There's lots of different possibilities, and things are going to go one way or the other. And so we thought to wrap up here, it'd be kind of fun for Beth and I to kind of do our own, Jimmy the Greek, if you will, kind of predictions about our own personal predictions about where things are going to go in 2017. Okay? And what we do plan to do is a year from now, we actually want to bring this slide back up here, and Beth and I will be on, and we will do a little retrospective of where we were right and where we were wrong and why. And hopefully that can help generate more learnings and takeaways. So I'm going to go ahead and start with mine. And, I think what I've heard and seen is that I think that there will at least be a temporary kind of slowdown in overall in APM applications, that's PML applications, perhaps compared to prior to the election, people thought we would be. And what we're hearing is that really could lead to an increasing, at least short-term participation in MIPS that is above what people thought it would be prior to the election. And it's merely because of what I described before in terms of some of the uncertainty around some of the models, and that's shared too, where MIPS, we're hearing from organizations of all sizes, might be kind of an attractive place to sort of hunker down for a while, frankly, and get at least through 2017 and use that as an opportunity to kind of see how things really shake out on the APM side. Because, as Beth mentioned, there's real hesitancy to go full bore into an APM when you're really not sure how long it's going to be around for, okay, and whether or not it has enough momentum and what's going to happen with the Innovation Center. But again, you can find out very quickly, and I could be proven wrong on this for sure, but generally, kind of that's what I'm hearing and sort of thinking in my mind. I won't be surprised if it goes this way. I think the other thing is we've gotten a lot of questions about how am I going to submit data for the different categories of MIPS. And I think there's a good chance there's going to be a lot that's inherited from the existing MU and PQRS submission and reporting systems. But if you really look at MIPS and what it requires from a reporting standpoint and some of the new options you have, for example, being able to report meaningful use or ACI as a group, right? That was never allowed before. If you really look at all those things that add up that's got to be done and that's been committed in the final rule, I think there's, in my mind, there's a good chance that the details, the practical details of submitting through a variety of different modalities is really not going to be available until relatively late in the year. And then providers kind of have to be ready for that, because then the subsequent quarter, that's the only quarter in which they have to report the data. So it's being kind of prepared for that big bolus of information about how to submit your data coming relatively late in the year generally. Again, CMS could very well be ahead of schedule on a number of things, but generally there's a lot of things they got to get to. And I think it's just something to be on the safe side to plan for. I've already mentioned that, I think the Medicaid, potential changes in Medicaid from the new administration and Congress may very well have a ripple effect onto the pay-for-value efforts at the state level. So if we're talking about Medicaid, innovation models, medical home models, and other things. I mean, even today there was just announced yet another new type of ACO out of the Innovation Center, which is a Medicaid Medicare hybrid ACO to handle and manage dual eligible beneficiaries. All right, and to the extent that involves Medicaid, then there could very well be some relationship there with what happens to Medicaid as a whole. But I do expect that there will be a ripple effect on some of those Medicaid state-level value-based efforts because of ACA modifications. I think this is one that's very late breaking. I had a lot of discussion here with both other folks in the industry and providers and federal side and others. And the 21st Century Act, by the way, I encourage those of you who are CHIME members or know about CHIME, the healthcare CIO organization, they wrote a very nice summary of the Cures Act that in particular highlights some of the interoperability provisions. Please send me an email if you'd like to get a little bit more information about that. I'd be happy to hook you up. But what we're hearing is that because that act really puts a lot of teeth into interoperability from a vendor compliance standpoint, that I expect that there will be pretty heavy R&D efforts, by the vendors to really execute on that, or at least be minimally compliant. And the other indication that we've seen of that is that we've also really, gotten word that a number of the major EHR vendors are really now going to be building or launching open application marketplaces, so that if they're going to have to do this, if they're going to have to enable interoperability, then they want to, of course, benefit from that economically if possible, with revenue share agreements and things like that with third-party app developers. So generally, that's going to be good for the provider community. But there's real action that's happening, and it's interesting how a number of these announcements have come out really on the same day that the president signed this bill into law, and new partnerships between interoperability organizations as well. It's just, so one can really feel that this act is really starting to cause some real action in the community beyond just the government, and that's going to be, I think, in some cases a distraction, for vendors as well, that now needs to kind of keep up with the times on that, on top of MACRA and everything else. I predict there's going to be some strain out there, and that's something to explore further, if you depend on those resources. All right, so Beth, go through your points here.
All right. So obviously, I'm taking a very kind of customer view to this, and I feel very strongly that providers are going to become very, very involved in their score. So what I mean by this is, again, going back to this public reporting, I do think that there are going to be, for expediency reasons and kind of investment reasons, where organizations are going to report as a group, and providers are potentially going to be slightly in the dark around what that score is and what that means, because simply, kind of resources to educate the market and make sure everybody understands it and understands all the levers that actually create to that is quite a bit of overhead. So I do think that while that is definitely going to happen in the market, I think the second that information starts to become public, and somebody can go in there and look at their own score or hear from somebody else what their score was, they're going to ask a lot of questions. So suddenly we're going to hear people getting very, very involved in finding out how I get my score up a little higher, or how that score is actually calculated. I think this is in particular going to be interesting for those people that are participating in ACOs, because all of the providers adopt the same score that is in the ACO, and I think that because of that alone, there's going to be a lot of questions.
Great. Let me get your next point here. There we go.
So I say that, I'm almost already changing predictions, which doesn't seem fair, right? Once you put them out there, you're supposed to stick with them. So I'm going to actually broaden this from just new ACI measures being published to address new provider types, to just an attention on new measures. So what I think is interesting and good in the rule is that they've really expanded the definition of eligible clinicians. And although that expanded definition won't be participating right out of the gate, the plan is for lots of different types of clinicians to be participating in MIPS. They recognize, though, at the same time, that all of these different types of clinicians can't participate if all of the measures that have been created so far really favor a typical primary care practice, really, where providers are seeing patients via visits and then collecting information during those visits in order to do reporting. So I think what we're going to see is, certainly on the ACI side, there's going to be some creativity to create measures so that they don't have to weight the ACI category down to 0 simply because it's not relevant to that provider type. So I think we're going to see some new measures that will address some of these new provider types that are going to be included in there. And I do think that there's going to be some attention on how to address this this kind of specialty issue, which is we hear this all the time in the market. You know, I have a whole bunch of specialists, and none of these measures apply to them. And even if you can find registry measures that do apply to them, they're non-benchmarked right now out of the gate because not very many people have been using those measures. And then at the same time, if there isn't investment in alternative payment models that are maybe down a specialty line, like, you know, the oncology care model is, then you don't have the option for those same specialists to participate that way. So I think the combination of all those things, they've got to address how specialists can do reporting, because that's going to be, having it continue to be not relevant for them is not going to help sustain the program. They need to make more measures relevant to more people. And then lastly, this is a conversation we have quite a bit when the light bulb goes off with, you know, various people in the room, when they realize that, you know, MIPS might be very simple if nobody ever leaves the organization and nobody ever arrives in the organization. So if everything's completely stable, then and your TIN structure is exactly what you wanted it to be, then maybe this isn't very complicated. But as we know, that is not the case. And new providers coming into your organization will bring along with them their MIPS score. So their 2017 MIPS score, if you hire them in 2018, in 2019, their penalty or incentive will be brought along with them. So we're going to see quite a bit more creativity and potentially even some structure and some best practices out there related to onboarding physicians that takes into account this kind of information, because it potentially has a significant dollar amount attached to it, and the people doing the onboarding are going to have to take that into consideration when either buying practices or hiring new providers.
Great. So again, we'll have the slides a year from now, and it will be a great topic of discussion. You know, I'm sure there'll also be other bullet points here. It will be like, oh, we didn't see that coming, right? That's just the nature of the beast. Great. Thanks for sharing that, Beth. And before we transition over in the Q&A, and some of the great questions have been submitted here, just a quick reminder of some of the educational resources that we do have. The one thing I do want to point out is we just published about a week and a half ago our brand new revamp for the final rule, 10 FAQs about APMs, alternative payment models. Feel free to take a look at that. I think it'll be a good resource for you to look at, as well as some of our other ones. I think for those of you who've been with us for over a year or so, we're almost at 500 members in the LinkedIn group now around MIPS. So check that out if you haven't. We'd love to have you there and engage you there. You know, lots of great discussions happening there too. So, Carol, I think with that, we're ready to take some questions. So go right ahead.
All right. So I think it will be interesting to see what happens next year when we come back and take our retrospective of what's going, what actually happened this year, and especially as you've both pointed out with the new administration. All right, so I'm going to jump in here, and as you alluded to earlier, half dozen questions here that a lot of people have been asking, so we're picking the most popular. First, are there any advantages to participating in the 2017 MIPS full-year reporting option compared to the 90-day one? The 90-day one. If so, what?
Yep, this is a common question. I think where this question stems from is when the pick your pace options for MIPS were announced by Acting Administrator Slavitt, and it initially appeared optically like, okay, you know, there's these very kind of discrete different 3 or 4 different options, and I got to pick one, and then I'm thereby then going to be bounded by how well I can really do, like in a very hard way. So it turns out actually those 4 kind of categorizations in terms of partial year, full year, et cetera, was really a different ways to kind of make it easier to understand what's really just one uniform scoring system. And so the quick answer to the question is actually, if you want to get a score of 100 on MIPS, it is possible to do that with only a 90-day window for 2017. However, your chances, particularly as an individual clinician, of getting to 100 points, if you only report 90 days of data, can be significantly held back if during that shorter period of time, for some of the quality measures, you're unable to get a minimum of 20 patients into the denominator of any given measure, which obviously the chances of that not reaching enough patients in the measure goes up the shorter your reporting window is, right? You just have fewer patients in there. And if that happens and you get, let's say, only 18 patients in that measure, whereas otherwise over the whole year you were well over 20, if you only have 18 there, then you're only going to get 3 out of 10 points on that measure. And so very naturally, there's a sort of natural scaling that the shorter your reporting window is, the greater the chances that you're not going to meet the minimum eligible case threshold for some of the measures, and they'll naturally bring your score down. Okay, so that's really what was being kind of educated. That's really the point of the education of the pick your pace type concept, which I thought was a great way to sort of get people oriented. But in the field working, you absolutely could get a score of 100 if, and we've got this written confirmation from CMS that by short reporting. But I will sort of finalize this by saying that the vast majority of organizations that we work with, they are intending on reporting on the full year, and they're really looking at that if something goes wrong, they can at least fall back to the 90. And in some areas like ACI, where it is a 90-day window, then organizations are like saying, okay, well, which 90-day window will give me the highest score, right? Does this sound familiar to anyone who's done meaningful use?
Meaningful use, right.
That. So we expect to see that, we're trying to work with some of our clients on that too, but that's the simple answer to the question. And I think the final piece is that people are already looking ahead to 2018. Because 2017 is upon us, look at the transition year, will be relatively easy to avoid a penalty, but that's not going to be good enough just to avoid a penalty. That performance threshold that you're compared to is going to rise substantially from what it is in the first year, which is only a value of 3. Okay, it's very highly likely to go up, because then the following year, in 2019, it has to, by law, equal the national average. And right now, we're down here with 2 points, okay? But up there, it's going to be, so where is it going to fall in between for 2018? We'll see. But organizations are orienting themselves to that this is really a competitive game with MIPS, and thereby, they're really saying, okay, ultimately we've got to get the full year reporting. Many of them are choosing to start that next year.
Okay. Can you explain more about the hospital list and the 75% professional charges around place of service? Is this for the ACI category only?
Okay. So what the questioner is referring to is that in meaningful use, ambulatory meaningful use historically, there's been a threshold of the percent of visits that a clinician actually gives in the hospital. If it's above a certain percentage of that clinician's visits, then they're going to be deemed hospital-based, and they will then be exempt from ambulatory meaningful use. Now, under MIPS, it does adopt the concept of a hospital-based clinician for the ACI category. However, it does lower the threshold to only 75% of visits or charges that have to be in a hospital in order for the hospital to be deemed, or for the clinician to be deemed a hospital-based clinician, and thereby get out of having to do ACI. The other thing is the final rule also expands the place of service code that qualify as hospital-based. It actually adds in the on-campus outpatient hospital. I think that's what it adds another code, so that further broadens the net. And then you also have a lower threshold, 75%, so before it was 90% of the visits had to be in there. I think the final piece about this to keep track of is that now under MIPS, CMS is intending to actually let organizations know which of their clinicians CMS deems them to be hospital-based based on their historical claims. And so, as we've seen with MU, there are reports that come back from CMS in terms of feedback or where your clinicians are, what attributes they have. I think under MIPS, as is in the case of the hospital-based information, I expect to see a lot more kind of information about your providers because the program is more complicated. To be coming back from CMS to be able to leverage those assets throughout the performance year can give you a real advantage. Right? But it takes time to obviously learn and leverage those assets, but there are going to be more of those generally than there were under the legacy programs.
Okay. Can you please explain MIPS ACO physician requirements, i.e. non-risk ACOs? What data, collected by whom, and submitted by whom?
Yeah, Beth, do you want me to take that one?
Sure. I'll kick it off, and then how about you weigh in? So the non-risk ACOs that they're referring to is those those types of ACOs that don't bear risk and therefore also have to do MIPS. So that's part of the question. So one of the specific tenets of that is that for the quality care, so if we're talking about a Track 1 ACO, for example, MSSP Track 1 ACO, one of the key tenets of that is that for the quality category, you must submit your data via GPro web interface. And that GPro web interface reporting will cross all of the different TINs that are operating within that ACO. So that's the first piece. The second piece related to ACI and the IA category is that in both of those cases, well, I'm sorry, let me start with the ACI case. In the ACI case, each of the individual TINs will report their ACI score individually, and that score will be weighted for the ACO overall based on the number of eligible clinicians that are in that TIN. So anybody that's an eligible clinician in that TIN, you have higher numbers that will be weighted, of course, higher to an overall score. And then these same organizations will get full points for the IA category. So the overall number that then is created will then be applied to all eligible clinicians in the ACO. So all eligible clinicians will then be attributed to the same score.
Yeah, thanks, Beth. And, yeah, I do. Yeah, I do. That's a great start. And what Beth, Beth, what you mentioned there was really for the the Track 1 shared savings ACOs. Certainly, that's getting back to all the shared savings ACOs. What you mentioned there is certainly true, and the final rule does have different categories of those MIPS reporting and scoring rules. So, for example, the next generation ACOs, where there's an ACO that if it unfortunately doesn't meet the qualifying participation threshold, they have to do a version of MIPS as well. And their version is where, for example, in the ACI category, they do have the option to actually report ACI at an individual provider level, within that model. But the scoring in terms of the weighting of the score up to the ACO level, that's exactly the same. The whole ACO is only going to get one score. And there's even yet another for all the other APMs that have to do MIPS, there's also yet a different set of rules, okay, that where the weightings are different among the different MIPS categories. Probably the only thing I'll add to what you said, Beth, is that one of the questions we get is that, okay, if I am in a shared savings ACO, which is Track 1 is the dominant one right now, and I have doubts about whether or not my ACO is going to get me a high score for MIPS, can I report MIPS as a full clinician on my own outside the ACO, and then can CMS take the higher of the two scores? Okay, this is a very natural question because people didn't join the ACO knowing that they'd have to rely on the ACO for their MIPS performance as well, right? Because MIPS, it's been so kind of later in the final rule coming out that you really had that clarity. And in the final rule, there's actually direct guidance, and I invite anyone, particularly ACO has this, feel free to send me an email, comment@ignite.com. I can actually point you at the page number, where it very clearly says that in the case of a provider that can get two MIPS scores, one that's derived from the ACO and one that's derived from reporting separately, that it will always be the ACO's MIPS score that takes precedence, regardless of which score is higher. Okay, so it's really CMS, and CMS, they actually really thought about this. They really want, for that ACO accountability to be the overriding. That's the whole goal, is trying to get people to move to APMs ultimately. And so they've already made a determination. So that means that, if you're tied to an ACO now, more than ever, you've got to really make sure your ACO is clear about whether or not it has MIPS exposure, and all the Track 1s do, because none of them are advanced APMs. We'll see what happens with Track 1 Plus that we mentioned before is being now created and will be launched at CMS. That might be a nice on-ramp to advanced APMs, but it's not clear yet. A lot of organizations be willing to accept the downside financial risk of even a 1 Plus. Okay, but the point is that ACO participants really have to ask their ACOs about how are you handling MIPS, what's our exposure, and then ask themselves the question of, am I comfortable with that level of MIPS upside or downside risk? Because that's really what it is with MIPS. There is upside and downside there. Whereas with Track 1 ACO by itself, there is no downside financial risk. Reimbursement-wise, there's investment risk, but not reimbursement revenue risk. It's just another thing to kind of think about. So I thought that was a great question that we got in there.
Mm-hmm. For the IA, it states that groups with 15 or less providers only have to report 2 activities. Is this only for groups?
So I'll take this one, Tom. This one has multiple layers to it, so I'm going to probably over-answer the question. So first off, what CMS did for small practices is it did make some accommodations, recognizing that small practices have fewer resources than some of what the large practices have. So in that case, what they've said is that you can, they only have to get half the points for that category in order to get the full credit. So that means either reporting 2 improvement activities, 2 medium weighted improvement activities, or 1 high weighted improvement activity in order to get those points. The second part of that question, though, was do they need to report as a group? So in that case, if you are a member of a small practice, whether you report as an individual or you report as a group, you will be attributed this same benefit, this same small group benefit. If you report as a group, only one of the individuals, only one of the providers within that group needs to have accomplished those IA category, those IA activities or improvement activities, that's repeating, in order for the whole group to get those scores. And that also applies to a large practice as well. So you do not have to have everybody in the group getting those activities accomplished in order for those activities to count towards the group score. That said, if you are a large practice and you report as an individual, which kind of almost makes that eligible clinician feel like they're a small group, they do not get the small group benefit because they are still part of a large practice. So they do not, the rules don't change for them just by them reporting as an individual. Make sense?
Yes, it does, a little bit, yeah. So time for one last question before we wrap up, and this is one we get actually probably in every webinar we do, and that is, how will ACI be submitted? Currently, we manually data enter meaningfully subjective information into the CMS portal.
Well, this tag team's on one of Tom's predictions. So one of his predictions is that we won't find out some of the new submission information until the fall, which I have to say I do
Q4.
agree with.
Yeah, Q4.
Q4, yeah. Right. I'm sorry, Q4 fall. So because of that, what the rule says, and why this question comes up and why it's confusing, is the rule lists a whole bunch of different ways that ACI can submit data. Theoretically, as part of the regulation. However, what they haven't put in place are a lot of the specifics around specifically how ACI will be submitted via, quote, registry or EHR direct. Like what's the file format? How will that actually look? So one of the options for submission is still attestation. So we would expect, given the timeline and given when we expect some of those details to be put out there, that most people will still be submitting ACI via the attestation, going out to a website in order to attest their providers, even whether they're attesting them as individuals or whether they're attesting them as a group. We believe that will be the interface that will be used.
Okay, great. And with that, believe it or not, we are all out of time. If we didn't get your question, and there are many that we didn't, you can certainly email me, Carol@HITECHanswers.com, or Tom at SAignite, or Beth at SAignite, and we will try to find an answer for you. We'll be back again in January, though, as we continue with our series, our ABCs of MIPS webinar series through 2017. Tom, Beth, thanks so much for today's show. It was great. And we'll see you, as I say, in the new year.
Happy New Year. Great. Thanks for being here.